everybody to this week's Grand Rounds. Before we start, I'd just like to acknowledge the traditional custodians of the land on which we meet, the Ngunnawal people, and pay my respects to elders past, present and emerging, and particularly I would like to acknowledge any Aboriginal and Torres Strait Islander people with us today. We're fortunate today to have the Gastroenterology department presenting. It's a tag team effort, I've been told, on gastric ulcers and lesions, and Andrew Thomson is going to lead off.
Well, good afternoon, everybody. Today, thank you, Tim, for that introduction. Today we're going to talk about a couple of cases that I've had, which was somewhat unusual, at least diagnostically. And I'm not sure whether Dr. Polizotto or any of the other haematologists are online, but I'd certainly welcome commentary from them at any stage during the presentation. Now, I can't seem to get the next slide, but how do you get the next slide?
This one here.
That one. Well, it's it. Okay. Well, maybe this one here then. Just press this one. Anyway, the first slide is a gentleman who was referred by one of the military doctors with features of, and this was the exact referral that I received in late October of last year. And he turned out to be a 38-year-old army officer, married with 2 children, with intermittent abdominal pain and bloating for 2 years. And the symptoms seemed to come on after a course of antihistamines. Really not much in the way of past history, and his medication similarly uneventful. Interestingly, he was of Southeast Asian heritage, but either he came to Australia as a very young infant or he was in fact born in Australia. So a gastroscopy was booked, and that was performed on November the 30th. This is the gastroesophageal junction at the which is normal, but in the stomach there was quite a marked ulceration, antropylorus. Now, importantly, this ulceration not only involved the antrum, but it extended through the pylorus into the duodenum. And that has actually quite important clinical significance, because in standard peptic ulcer disease that doesn't usually occur, nor does it occur in gastric cancers. If a lesion ulcer goes right through from the stomach into the duodenum, it does suggest a lymphoma. Anyway, biopsies actually didn't confirm that, but they did confirm Helicobacter infection, and he was treated in the usual way with triple therapy for Helicobacter. Now, the repeat gastroscopy was performed, but unfortunately, as you can see here, the changes were more pronounced there, and he was actually much more symptomatic. He had lost weight. He didn't have any systemic symptoms, but he wasn't feeling great. He had a lot of epigastric pain, and he had lost weight, and the ulceration was more extensive. And once again, it was noted to be extending from the stomach into the duodenum in the way that I've tried to show there. He also had incisurational ulceration. The incisura is the part of the lesser curve of the stomach, which it forms a ridge. So it's best actually viewed when the scope is slightly J-shaped, and you're looking up at yourself from the distal gastric antrum. Anyway, the biopsies on this occasion were in keeping with a diffuse large B-cell lymphoma, and I was interested if the haematologists have got, if there's anyone in the audience who could comment, but this pattern immunocytochemistry, particularly the CD20 positivity and also the CD5 positivity, whether those are other negative markers, the cyclin D1 and so forth, being negative, is quite characteristic for a diffuse large B-cell lymphoma. And yes, this other thing was, of course, really way over my head. But apparently all of this is, yes, Fatima wants to comment. Fatima, how can I put her on? Can she just comment? Can you just comment, Fatima? You wanted to say something? Oh, we can't hear her, so you might be muted. Anyway. What if I press this here? Maybe that will help. No, that's muting me. No, that's not good. Okay, all right.
She's saying that she is saying she's muted.
All right. Okay. All right. Well, we'll keep going then. I mean, Fatima, if you wanted to, if you keep talking, and if we hear you, we'll let you know.
I had a comment in the chat.
Oh, right.
Diffuse large cell.
Right. Okay. All right. Now, some of these other immunohistochemical features, as I say, are a little bit above me, over my head. I thought the Hegel staining is very interesting. It's something I hadn't heard of before. And this is a picture of Hegel, the great German philosopher. But I think obviously it's a bit different Hegel from what we're talking about here. Anyway, to return to the real world, interestingly, there are a couple of interesting points here. The first is that I had to go back and do further biopsies of the, so the attending pathologist wanted more tissue. And I think if you do suspect lymphoma, you need to take extra tissue and put it in a standard non-formalin jar, so that to maximise the information that's obtainable. The second thing is that the patient not unreasonably wanted a colonoscopy at the same time. And interestingly, I at the colonoscopy, there was this laterally spreading lesion in the sigmoid colon, which you can see here. And this is what we call, and Dr. Ahmadzai is going to talk about this a little bit later, but nowadays at colonoscopy, we can tell a lot from just morphological appearance. It used to be that it was all on the biopsy, but now when you see a lesion like this, unless you strongly suspect that it's a cancer, you don't generally biopsy it. You generally bring the patient back with a view to removing it endoscopically. And that's indeed what I did. After taking informed consent, the lesion was lifted with a blue coloured dye with Angela fusion and adrenaline solution, and with a series of incisions with a snare. It was completely excised, and the margins were treated with soft coagulation to reduce the risk of recurrence. And the plan is for him to have, this was quite unexpected, and the histology was a traditional serrated lesion, which is precancerous, but definitely not cancerous. Anyway, once upon a time, that lesion, certainly 10, 20 years ago, certainly when I was a registrar, that lesion probably would have gone for surgery, but not anymore. We did a CT PET and referred to the hematology department, and the CT PET showed a diffuse thickening of the gastric wall with lymph node avidity and involvement of the lymph nodes around the stomach, but no involvement further on or further afield. So that's the end of the first, and he's obviously commenced on R-CHOP chemotherapy. Right. Okay. So we all got that? Okay. So yeah, sure, Paul. Yeah.
There's an association of Helicobacter pylori with multiple lymphoma.
Yes.
How does one differentiate between a large B-cell lymphoma and a multiple lymphoma? Seems going to address that, or if fashion might progress.
Yeah.
Might
Well,
be difficult under the on that to the end of the study.
sure. I mean, to answer your question directly, Paul, I mean, I think you can differentiate them histologically and immunocytochemically, but the interesting thing is, and I'll come back to this, seems to be an overlap, and DLBC L may in fact be extension, if you like, or some multiple lymphomas may actually turn into DLBCs, and that's very interesting because there is an association between Helicobacter and DLBCL as well.
And the point that I want to make is sometimes multi-lymphomas improve with HP and
Oh God, yes, and so do DLBCLs as well, which is interesting. Yep.
So we might comment on
Yeah.
at the end.
Okay, but yeah, no, these are really good points, though. Really good points. Yeah, sorry, what's the question? Fatima, could you please add your comment to the chat? Oh, right. Yeah, CMC and all those things usually done to determine if double hit or triple lymphoma worse prognosis. And he is doing well and excellent response to treatment after 3 cycles. Okay, so yeah, obviously, it's interesting because this CHOP therapy was around when I was a boy, and it's because it's so effective, it's maintained. It's hard, I guess, to do randomized controlled clinical trials when the existing therapy is so good. Anyway, this second case is quite interesting as well. It's different. So we're talking about 37. This lady is an elderly lady. First contact was in 2009. 69-year-old divorced lady with 5 children who presented to me at that stage with shortness of breath, and I investigated her for iron deficiency anemia. And I did find a duodenal lipoma at that stage. And I did a repeat colonoscopy in 2015 with further adenomatous polyps. And this, the lipoma was resected. This is actually, this isn't the case. This is another case that one of the interns published a few years back. And this demonstrates how lipomas can bleed. And what I did with this one and the one I just described was put an endoloop around there. Can everyone see that? Yeah, an endoloop around, so like a surgical ligature around the base of the lesion, and then you cut it off in a standard fashion. And it's this one looked like it looked like a finger, so I thought it was worth putting in the Christmas edition of the MJA. Anyway, this lady was re-referred, now 83 in 2023, with some progressive, non-progressive dysphagia. For the medical students in the audience, whether dysphagia is progressing or not is really a very key point in the history. No adenophagia and a gradual loss of weight over 2 years, which she attributed to stress. And she also had some slight alteration in her voice, raising the possibility of an oropharyngeal cause for her dysphagia, such as, for instance, motor neurone disease or Parkinson's, but that certainly wasn't confirmed on examination. And she herself felt that it was due to a hairspray, and her voice actually wasn't really all that bad. She didn't really have any, hoarseness or dysarthria to suggest a bulbar disease of the brain. Anyway, she, for her age, she was actually very well, and my differential diagnosis was candida and of the esophagus, possibly related to the asthma inhalers or a Shatsky ring from previously diagnosed reflux disease. But at gastroscopy, I found this. The esophagus was normal, but there was this lesion here, and you can just here, and you can see it quite well on retroflexion. So this is with the, as I was talking earlier about having the scope positioned in the distal stomach. You're looking back up at the body of the stomach, and you can see it quite well here. It's got a central depression in the middle, and it's got a rim of elevated tissue, but no ulceration. And this is using narrowband imaging. You can also see that the pit pattern is slightly altered in the lesion. Now, I actually thought this might be a case for Dr. Aslam or some other Sydney-based person to do what we call endoscopic submucosal dissection. And this is being used more and more in gastroenterology, where you inject the lesion in the way that I described earlier, but instead of taking it off with a snare in a piecemeal fashion, you use a needle knife and you cut the lesion, you peel the lesion off the gastric wall. So really quite an exciting technique. The only problem is that it can take up to 4 or 5 hours to do this if you've got a big lesion. So it has its limitations, and the training required to get expertise in this area is really quite significant. Anyway, it turned out that the biopsies actually turned out that this was a malt lymphoma. And this, again, I'd welcome commentary about this, but the key things are the CD5 and the CD20 are positive, and this combination of immunohistochemistry does suggest malt lymphoma. Anyway, so that's the second case. But before handing over to Dr. Ahmadzai, has anyone got any questions about the cases or anyone comments? Or yeah, we've got some comments here.
So Dr. Hasib,
Yeah,
several RCTs.
several RCTs since 1992 have attempted to demonstrate superiority of various regimens over R-CHOP. Nothing to date has improved. So R came along in 2005. So, when I was a resident, which was before 2005, it was just CHOP, but now rituximab has now been added to the regimen. So now they give rituximab and CHOP therapy. Okay. All right. So we might just move on. Dr. Ahmadzai is going to talk about the nuances of endoscopic diagnosis of gastric and colonic lesions for 5-10 minutes.
Okay, thank you, Dr. Thomson. So just following on from that, so I just wanted to just briefly discuss some of the things we commonly see in gastroenterology. And so one of them is polyps. So polyps can occur anywhere in the gastrointestinal tract. They can come in various shapes and sizes. They can be sessile, they can be serrated, and they can be pedunculated, as for example in this island here, or they can have areas of central ulceration and depression. So similar to, this is a picture of Lake Hillier on Middle Island in Western Australia. I thought it's a sort of a good analogy. And so polyps are now being described as what we refer to the Paris classification system. So this was devised in 2002 by an international consensus group of endoscopists, surgeons, and pathologists in Paris. And it's being utilized now in a way where we can actually identify which lesions can be amenable to endoscopic resection and which lesions we have to refer on to the surgeons to resect. Now, in terms of describing these lesions, so they're classified in terms of either protruding lesions, which are Paris 1 lesions, and these are subdivided into Paris 1P, which are the pedunculated variety, or Paris 1S, which is sessile, or something in between, which is the 1SP. And then we have the flat lesions, which are referred to as the Paris 2 lesions, and these can be completely flat, as in a Paris 2B, or slightly elevated, as a Paris 2A. Or there could be mucosal depression in terms of a Paris 2C lesion. And in addition, there's also Paris 3 lesions, which are excavated lesions. And these are more concerning, these particular subtypes, when there's depression or ulceration, and they indicate that there might be more deeper submucosal invasion or potentially cancerous infiltration deeper into the layers of the gastrointestinal tract. So just some examples of these. So a Paris 1P lesion, this here is a large pedunculated lesion with a very thick stalk, which is just an adenoma. And this is an example of a Paris 1S lesion in the second image. So it's a sessile raised lesion. And then we have a Paris 2A lesion here, which is only slightly raised. So the difference between the Paris 1S and Paris 2A is that if it's greater than 2.5 millimeters in height, which is the size of the biopsy forceps, then it's categorized as a 1S lesion or as a Paris 1 lesion rather than a Paris 2. This is an example of a Paris 2B lesion. This is in the esophagus. It's a completely flat lesion, but we can see it on near focus imaging. We can see the abnormal tissue there. And this was an early esophageal cancer. And this is an example of a Paris 2C, 2A lesion with areas of central ulceration and raised edges. And this is similar to Dr. Thomson's second case. And this is an example of a Paris 3 lesion with a very deep cratered ulcer, which is very concerning for underlying malignancy. Another classification system we use in gastroenterology is the Kudo classification system, which was devised by Professor Kudo in Japan in the mid-1990s. And this is an endocytoscopic classification system where we assess the mucosa and the crypt pattern or the pit pattern of the mucosa on near focus imaging. And the normal pit pattern of normal gastrointestinal mucosa is referred to as this type 1 pattern with normal round pits, whereas type 2 is this more stellar or asteroidal type lesions, and we see these typically in hypoplastic polyps in the colon, whereas type 3 has this sort of speckled or pepper pot appearance, and these can be either divided into 3S or 3L, and the 3L is the tubular variety, and these are more characteristic of adenomas. Whereas the type 4 lesion has this cerebriform appearance with a gyrus-like pit pattern, and these are more characteristic of tubulovillous adenomas. And the type 5 pit pattern is this amorphous non-structural pattern, which we often see in more high-grade lesions or cancers. And we can use both the Paris classification system plus the Kudo system to identify which lesions we can resect and which ones we need to refer on. So again, this is just highlighting those examples, just with some images of normal mucosa, hypoplastic polyps with type 2 Kudo pit pattern, and lesions which are adenomas in terms of Kudo type 3 and 4 lesions, and then more aggressive cancers. So as you go down the list, there's a higher need or indication for surgery and worse outcomes. So how does this actually relate to or correlate with the risk of cancer? So the Paris group in 2002 also published some data of about 11,800 patients, and they looked at the risk of cancer stratified based on the appearance of the polyp lesions based on the Paris classification, and also stratified according to the polyp size. So when you subdivide the lesions, you can see that the bigger the lesion gets and the more flat or ulcerated it is, the higher risk that it's harboring an underlying cancer. And so now moving on to gastric ulcers. So these are typically mucosal defects or erosions or more deeper ulcers that can extend to deeper submucosal layers. The majority of patients we see are actually asymptomatic. They may have a little bit of dyspepsia and epigastric pain, which is worse on eating, and they may present with iron deficiency anemia as well as another important cause of, or another important differential diagnosis when you're working up someone for iron deficiency anemia for the medical students. Patients may have some associated symptoms such as heartburn, acid reflux, vomiting, and typically in the acute setting, we often see these patients coming in with gastrointestinal hemorrhage. And they can also perforate and require surgery, and they can also be less commonly complications such as fistulization to adjacent bowel, for example. So how do we differentiate between benign and malignant gastric ulcers? So typically, I'm sorry, this is the way, I'll just move that just to the side. So typically benign ulcers are usually less than 2 centimeters in size. They're very smooth and have regular round edges. Whereas in malignant gastric ulcers, as in similar to the case that Dr. Thomson presented, these are very large, greater than 2 centimeters, punched out lesions, very irregular, nodular, thickened borders, overhanging. These are more concerning for underlying malignancy, but we often have to take 4-quadrant biopsies to confirm the diagnosis. So with that, I'll just pass back to Dr. Thomson, just to...
Does anyone have any questions about what Dr. Ahmadzai is talking about? Yeah, Ashwin, yes.
Thank you.
We need to have one classification based on it. Yes, so thanks, Hasib. Just a question about when you are deciding whether it's what kind of classification is that? Do you do it at the time of endoscopy, or is it based on your endoscopic photos after? And I guess the second question is there much inter-rater variability about?
Yeah, they're good questions, and there is inter-observer variation. The other thing, to preface my answer to that, the Paris classification should really only be used for lesions over 2 centimeters, because all that subtlety of morphology, we're talking about craters and, the Ayers rock appearances, the 1S and so forth. I mean, you can only really, that really only takes on meaning if the lesion's quite big. So the first thing is it's a minority, a small minority of polyps which are amenable to the Paris classification. And you should make your decision at the time, but you see a lot of, I'm ashamed to say, I put my registrars through the griller, and Dr. Ahmadzai has felt my questions at pretty well every endoscopy list. I ask him about the Paris classification and I ask them all, but many general gastroenterologists, because they don't deal with these large lesions, they often don't know the nuances of the Paris, because it is confusing and not very intuitive, the Paris classification system. But nonetheless, the Paris classification system has been shown to be predictive of cancer. I can't give you chapter and verse on inter-observer variation, but it's not that bad that it precludes its use in publications and trials and so forth, in terms of endoscopic removal. Yeah. But you should make the call at the time of the first endoscopy, and preferably take pictures, so that if you or one of your interventional endoscopy colleagues to whom you refer the case can look at the pictures and make an evaluation in the consulting room and say, yes, we can have a go at this. And but sometimes when you get in there, the second time round, you pull out. You say, well, this is obviously a cancer. I'm not going to take this off. You take biopsies and get out. So, but I think it's a good point, Ashwin, what you're saying. It's not perfect. Paris isn't perfect. All right. Well, somebody else here. Yeah. Hi. Yes.
Apart from the size of the polyp, don't the location or history make any difference in the prognostication of the polyp?
Yeah, the size, if it's, as Hasib says, if the larger the polyp, the more likely it is to be cancer. But size isn't of overwhelming importance. It's morphology, which is of overwhelming importance in terms of that. The second question, does location matter? There's a recent publication from the Sydney group which shows that rectal laterally spreading lesions are more likely to harbour cancer than ones further up, but it's only slightly more likely, yeah.
And also histology.
Well, you can take histology. The problem with histology is that it's not representative of the whole polyp. So often you take a biopsy, particularly, and the biopsy is benign, but when you try to remove the polyp, it's got malignancy underneath. So yeah, so histology, but pinch biopsies isn't really that great. It's better just to leave the
sampling error.
Yeah, so it's better just to leave the lesion and refer to surgery, or refer to an interventional endoscopist, or if you yourself are an interventional endoscopist, bring the patient back and talk to them, and because it's a higher risk. Doing a endoscopic removal of a large polyp entails a higher risk of perforation and bleeding, and therefore you need to take special consent before you do that. It's not, you shouldn't do it at the time. Well, no, you shouldn't do it at the time. No.
But you don't always agree on that. But what about like considering this coming? You're going to repeat the question now. The significance of ulcers and difference.
Oh yeah. That's interesting, Paul, because you and I, lesser curve is more likely to be benign, whereas greater curve more likely to be cancerous. Yes, that's what you were taught. Yeah. The trouble is we don't see much pathology anymore because of the widespread use of the PPIs. All these old guys with their gastric ulcers who used to come into GI clinics have largely disappeared, you know. Anyway, all right, so let's move on. Well, let's finish off now. I just wanted to round out by just talking about gastric lymphomas. It's a shame that one of the hematologists isn't here in person, because it really would help. But basically lymphoma is divided up, as you can see there. And in terms of the gastric lymphomas, there are two main types, and I think this presentation demonstrates it quite nicely. The first case I presented is a DLBC, and the second case is MALT, and the other lymphomas are pretty. This last one here is the one that you get in untreated celiac disease. And GI lymphomas, the predominant GI is the gastrointestinal tract is the predominant site for extranodal lymphoma involvement, and it can present at any site, but the stomach is the most likely or the most common place where their lymphomas present in the gut. It's much more common to have a gastric lymphoma than in any other area in the gut. Interestingly, also there is a variation internationally in terms of lymphomas in various parts of the world. Burkitt cell lymphoma is much more common, for instance, in Africa, and in the Middle East and the Mediterranean, the small bowel lymphomas are much more common than in Western populations. Now, the predisposing conditions to this lesion, Helicobacter 1, 2, and 3, these other diseases are not really nearly as important. I mean, obviously, celiac disease is a cause of, or predisposes people to lymphoma, but even it's fair to say that even in untreated celiac disease, a majority of patients do not develop lymphoma. Inflammatory bowel disease does also predispose people to lymphoma, but in fact, it's often the treatments that are used that increase the risk, not the disease itself. And the treatments give you a hepatosplenic lymphoma, which a T-cell lymphoma, which is different from the lymphomas that I've been talking about today. All right, gastric lymphomas. Again, I think I've covered all of this, and the one thing I did want to come back to was the fact that there is an overlap between diffuse large cell B-cell lymphomas and MALT lymphomas, to the extent that they are both linked to Helicobacter infection, and the treatment with anti-Helicobacter treatment is efficacious, certainly in MALT lymphoma, and to a lesser extent in diffuse large cell B lymphoma. MALT lymphoma it has a variety of treatments, but I think it's fair to say in this lady the appropriate treatment would either be triple therapy or indeed no treatment at all. You can treat it with radiotherapy, and you can also treat it with surgery, but it would be, in this day and age, it would be relatively few patients who would merit that sort of treatment. There are some predictors. The presence of a so-called CAG-A H. pylori infection makes you more likely to develop mold lymphoma, as does this particular translocation. Also is associated with a more aggressive outcome or more aggressive manifestation than if it's not present. The other thing is that there is in vitro data that the Helicobacter will induce a lymphocytic reaction, antigen presentation, and thereby increase B cell proliferation. But it's only in a subset of patients, a subset of Helicobacter type organisms. It's not most Helicobacter organisms do not do this. Okay, so I thought we would finish up there. Has anyone got any questions before we finish?
Open up the chat function to see any questions online. So if people do have questions in the audience, we'll repeat them rather than run around with a microphone for those online. Okay. You make the font bigger. I'm sort of age challenged. I can't read the... Any questions from the audience? Nicole?
Patients with mold lymphomas, for your mold lymphoma patients, how often do they require surveillance gastroscopies and things once they've been treated if they're in remission?
Yeah, I think I think they do. As a rule of thumb, I think after the initial, you'd obviously surveil them again in a few months, and then a yearly gastroscopy after that. Yeah, but I don't think there are any clear data about this. In this lady, in her 80s, it's a really. It'll be interesting. She's actually been referred to Dr. Polizotto, who. And it'd be interesting to see what they think, but I don't think they'll be too aggressive, given that the mold lymphoma isn't causing her any symptoms at the moment.
Okay, nothing on the chat function yet. Any other questions from the audience? You may have mentioned it, Andrew, but does the association with Helicobacter in all cases have an effect on prognosis with the malt and diffuse large cell lymphomas? Association doesn't necessarily mean obviously
absolutely. But certainly in malt lymphoma, the eradication of Helicobacter does often, as remarkable as it may seem, the eradication of the Helicobacter cures the disease, and that's very impressive, really. It's one of the few examples in medicine where antibiotics can actually cure cancer, but that's not the case with the diffuse large B cell lymphomas. It's not that you can give triple therapy for those patients, but it's certainly not going to cure the disease. So to answer your question, in terms of malt lymphoma, it certainly is more than just an association, because treating it cures the disease. Yeah, Paul.
Thank you. Do you have any figures in your head about the relative risk of patients with HP infection getting gastric cancer and mold lymphomas?
Well, we'd be pretty low, Paul. I mean, obviously we're talking about less than. Say medicine everything's 1%, 10%, 50%, or 90%. But I would say 1% would be more likely than 10%. But it's certainly a small minority. Now, you've got to remember that up until 70-80% of the population of Africa has endemic Helicobacter, and most of them obviously don't develop gastric cancer or gastric lymphoma. And as I said, it's only a small number of subtypes of Helicobacter which seem to have induce the immunological response in the B cells that is consistent with lymphoma development. So yeah, it's a minority. But a CAG-A Helicobacter, it'd be interesting. I think it's a very interesting area because it'd be nice to subtype the Helicobacters, and then we could focus on eradicating the ones that really are important in terms of gastric carcinogenesis, you know.
And there's also the peptic ulcer disease.
Yeah, but that's a bit easier because you know, you tend to eradicate it no matter what under those circumstances, you know.
I think that was
Yeah,
the last question in chat that's saying whether other cancers associated with Helicobacter pylori.
Don't know. No, I don't. Yeah, various people think there are. That bloke in Sydney was very big on. I mean, Peter Catalaris. He thought that Helicobacter might. There've been all sorts of little case histories in the literature, but I think the short answer is not. No, there's nothing definite. No. Yeah.
Do you look for regional issues?
Sorry. Asian list of gastric cancer. Yeah, well, Asians, in particular Japanese, have a higher risk of gastric cancer, but the actual pathogenesis of that is unclear, and it may be definitional to the extent that the Japanese call gastric cancer when it's not. We wouldn't call it gastric cancer. So, but certainly the risk of gastric cancer in Asia, and particularly Japan, is higher than that in the West. Yeah.
All right. If there are no further questions, I think we'll draw the session to a close, and I'd like you to join with me in thanking Gastroenterology and Speakers Clinics.